Good afternoon, everyone. So my talk is short, and I promise not to use the whole 30 minutes, and happy to take all your questions at the end, but we're going to review uncomplicated gram-negative rod bacteremia. I don't have any relevant disclosures, and I really have, I kind of start with the end. I really have 3 points I want to communicate, 3 things that I hope you'll incorporate into your practice as clinicians and advocate for the other prescribers you interact with to change their practice. 1, we should really stop treating bloodstream infections, gram-negative bloodstream infections, for 10 to 14 days. We know that 7 days is adequate for most patients. A few caveats we'll talk about, but for most patients, 1 week of therapy is adequate. Patients who are improving on their initial IV therapy can be switched to oral antibiotics to complete treatment. We'll talk about the caveats to that, but in most cases that's appropriate. And for most patients, we should not be obtaining follow-up blood cultures. There was some data suggesting that this may be beneficial, a little bit of buzz about that at ID Week a couple of years ago, and there's subsequent data that has really called that into question. Okay, and I'm going to go through these point by point. So first off, we should be treating gram-negative rod bacteremia for 1 week instead of longer durations. What do I base that on? 3 recent randomized controlled trials, all published within the past 3 years. Yahav, Van Dijk, and Molina. These are all randomized controlled trials that compared different durations of therapy. Yahav and Molina compared 7 to 14 days. Van Dijk was a 3-arm trial that compared 7 to 14 to CRP-guided therapy. I'm not going to talk about the CRP-guided arms. I'm really focused on the fixed duration regimens. They actually enrolled a pretty diverse patient population. Both Molina and Yahav had substantial minorities with active malignancy. Yahav had another 25% with some other underlying form of immunosuppression. One important limitation to the generalizability of these studies is all primarily enrolled bacteremia associated with urinary tract infections. Interestingly, they all had very similar inclusion-exclusion criteria. So you had to be better to be enrolled in the trial. Better meaning you're afebrile, you weren't requiring pressors, within day 3 to 5 of therapy. You couldn't have an uncontrolled source of infection or some other form of infection that we know needs a longer course of treatment, like osteomyelitis or a device infection. And you couldn't have any real high-grade form of immunosuppression. So they weren't enrolling folks who just had stem cell transplants, who had advanced HIV, or who were neutropenic. They all had really patient-centered outcomes. 2 used a composite outcome of clinical failure and mortality and readmission, and then 1 was really focused on clinical failure and powered for that, but also reported mortality. I didn't include the statistics here, but these were all designed as non-inferiority trials with a non-inferiority threshold of 10%, meaning enrolling enough patients to demonstrate that the shorter course therapy isn't at least 10% more likely to have a treatment failure or mortality. And what they found was the non-inferiority in every single case, both in terms of the primary outcome and in terms of mortality. So patients who were better by day 5 and concluded their therapy at 7 days were not more likely to experience treatment failure, mortality, or readmission in all 3 of these trials. And I think that's the most compelling data, but I also want to point out that because it's a little limited to Enterobacteriaceae, meaning non-Pseudomonas, non-Stenotrophomonas, bacteremia in folks who mostly had bacteremic urinary tract infections, that all of the other observational data in other patient populations suggests the same thing. Now, because this is observational data, I think it's a little bit more problematic. So when we think about retrospectively looking at patients who received different antibiotic treatments for the same infection, we really have to be worried about confounding by indication, meaning the folks whose treating physicians know that they are not a setup for success, say because they didn't have clinical resolution of their symptoms within a few days of starting therapy, or because they had uncontrolled sources of infection. They may be more likely to be given longer course therapy, and that kind of implicitly biases these studies to not find a difference between the shorter and the longer courses, even if the shorter course is maybe a little bit worse. Nonetheless, I think if you start with the knowledge that we have these really well-designed clinical trials showing that 7 days is just as good for a very related condition, now we look and see in all these other maybe higher risk subpopulations, we see the exact same thing. So in Pseudomonas bacteremia, in carbapenem-resistant Enterobacterales bacteremia, in folks who started off critically ill from the gram-negative bacteremia, and even in 2 studies of patients who were specifically excluded by these trials. So folks who were neutropenic, had an active hematologic malignancy, or even had just had a stem cell transplant, the shorter course therapy looked about as good as the longer course therapy. There's one study kind of in the middle here, this McAdyer study, which showed overall actually worse outcomes with short course therapy. However, when they dug into that population, that was really driven by folks given short courses of low bioavailability oral beta-lactams. And if you looked at folks who were given high bioavailability drugs like fluoroquinolones or Bactrim, they did just as well with short course therapy. And that's the thing we're going to talk about next. So my point number 2, most patients, once they are better, can be switched from the IV to the oral route of therapy. Again, what do I base this on? A randomized controlled trial. This is a multi-center study of 174 adults with an Enterobacterales bacteremia who had at least 3 days of IV antibiotics and were improved by the time they were randomized. They excluded patients who'd had endocarditis, CNS infection, intense immunosuppression, and they randomized them to either complete IV therapy or switch to one of 3 classes of drug, an oral quinolone, trimethoprim sulfamethoxazole, or an oral beta-lactam. Again, they had a composite outcome that included death, recurrent infection, readmission, or treatment failure, need to give more antibiotics. Their study was designed as a non-inferiority trial at a 10% margin. They unfortunately were not able to finish enrollment, so this study was stopped at about half enrollment. Nonetheless, they actually found non-inferiority at a 10% margin, but it was a little bit underpowered. Again, this patient population, like the other clinical trials, is predominantly folks coming in with bacteremic urinary tract infections. A substantial minority had an ESBL, gram-negative organism. The median duration in this trial was a little bit longer, it was 12 days, and about 2/3, interestingly, switched to an oral beta-lactam. And I say interestingly because that, in my mind, sets this up to be a trial that shows the oral antibiotics aren't as good. That's what the subsequent data shows. But actually, that's not what they found. They found that their 90-day treatment composite was similar between groups. Actually, it was a little bit lower in the folks switched to PO. And then when they looked at the subcomponents of that composite outcome, mortality, relapse, readmission, need for additional antimicrobial therapy, they found similar outcomes in every single group. In addition, the median length of stay was actually shorter in the folks who switched to oral antibiotics by about 3 days. And there were no differences in adverse events, serious adverse events, or adverse events that required us to change antibiotic therapy. Now, I want to point out that this isn't just one clinical trial, because if we actually look at the 2 clinical trials that compared short versus long course antibiotics for gram-negative bacteremia, well, the Yahav study primarily switched folks to oral agents, predominantly fluoroquinolones, and reported very good outcomes. And then in the trial by Von Dock, they allowed PO switch at the prescriber's discretion at any time, and they actually went back and looked at that and found that having early oral switch versus completing all IV therapy was not associated with outcome. There are a few old, small retrospective studies that have also compared oral agents, mostly fluoroquinolones, to IV agents, and all suggest that the 2 approaches work just as well. I wouldn't hang my hat on these. I think it's really the clinical trial data that makes this case most compellingly. Now, you may say, but my patients, they're sick. I take care of transplant patients. I can't use PO agents. I need to use the stronger IV antibiotics. There's actually a 200-patient study that looked at this, comparing oral versus IV purely in solid organ transplant patients. And they, again, found the exact same thing. Not only was there no difference in recurrent bacteremia, but actually there was a substantially higher rate of C. difficile infection in the folks who were kept on broader spectrum IV therapy. and as well as an overall increase in serious adverse events. But with switch to PO, not a single patient died, the length of stay was shorter, the clinical outcomes were the same. Now, what are the important caveats to the general message that we should be using oral antibiotics? Well, not all oral antibiotics are created equal. And when we talk about drugs that don't have high bioavailability, where we have a plausible hypothesis that the oral antibiotics won't work as well, we're really talking about oral beta-lactams, in fosfomycin, but please don't use fosfomycin for bloodstream infections. We're really talking about oral beta-lactams. Also point out that this is not only a bioavailability issue. The total dose of oral beta-lactams is substantially smaller than their IV counterparts. So for example, if you give someone 300 milligrams twice a day of ceftonir, you are giving them less than half the standard dose of ceftriaxone, and also ceftonir's half-life is like 4 times shorter. So, when you factor in bioavailability, you also only absorb a fifth of the total amount of ceftonir you're giving the person. Use ceftriaxone instead. That's like 10 times, 30 times higher tissue exposure for that bacteria. So it makes sense that those drugs might not work as well. And indeed, when we look systematically at the retrospective literature of switch to PO and gram-negative bloodstream infection, and we compare folks switch to oral beta-lactams versus folks switch to higher bioavailability drugs, in this case quinolones, we find that there is this association between recurrent infection and possibly more recurrent bacteremia. Now, not every study has shown this, but the studies that have not shown the inferiority of oral beta-lactams, A, use very high doses of oral beta-lactams, and B, use those longer durations, more 10 to 14 days, not those shorter durations. And in fact, one of my favorite of these trials, published last year, actually stratified the outcomes with oral beta-lactam by the dose given. And they found that, first off, as a whole, the oral beta-lactams yielded poorer clinical outcomes than the oral fluoroquinolones or Bactrim. However, that was being driven by standard dose oral beta-lactams, which did terribly compared to the oral fluoroquinolones, versus if patients were being prescribed the maximum on-label tolerated dose of the oral beta-lactams, they actually worked just as well. So if you're going to use an oral beta-lactam, use the highest dose the patient will tolerate. Now, there's more to consider than the drug. We also need to consider the patient. Obviously, folks who are throwing up their breakfast are not great candidates for oral antibiotic therapy. But we also need to consider, are they going to be able to absorb that medication? So there's a very nice study of folks who'd had an extensive small bowel resection where they gave various what we generally consider to be high bioavailability drugs, clindamycin, ciprofloxacin, fluconazole, and they actually measured the blood and tissue levels that were achieved with the thought to be equivalent oral and IV forms. And what they found was that for quinolones, for ciprofloxacin, in the short gut patients, the oral dose was achieved substantially lower concentrations in at least some patients. And this really suggests that unless we have a means to do therapeutic dose monitoring and ensure the levels of therapeutic, we should be cautious about using oral antimicrobials in patients with bowel resection. And then, although I don't have a ton of peer-reviewed literature to point you towards, I would say as a general rule, I am more cautious about using switch to oral beta-lactams in patients who are at higher risk for treatment failure, knowing that the retrospective data shows that as a whole, they tend to be associated with poor outcomes. And I'm also a little bit cautious in folks who have severe obesity. And we haven't published it yet, but we presented as a poster at SHIA. When we looked at our own outcomes in bone and joint infections, which is most of what I do, we found a lot of our failures with the oral beta-lactams were in patients who had greater than 120 kilograms, BMIs in the 40s and 50s. And that makes sense because their volumes of distribution are larger. And the last point, for most patients, we should not be obtaining routine follow-up blood cultures. So why is this even a question? First off, we know that most follow-up blood cultures in gram-negative bacteremia are negative. And we know what are the major risk factors for having a positive follow-up blood culture. It's having a device, having end-stage renal disease and a catheter, having not been put on appropriate therapy right away because you ended up having a more drug-resistant pathogen, and then clinically not responding to the antibiotics we're giving you. Well, there was a meta-analysis done a couple years ago that looked at patients given versus not given follow-up blood cultures, and they found that there was lower mortality in the folks who received a follow-up blood culture, also longer length of stay and longer treatment duration. But there was a big buzz about this. It was like 4 or 5 retrospective studies that all showed the same thing, and then the systematic meta-analysis that suggested, well, maybe we need to routinely be looking for persistent gram-negative bacteremia so that we don't miss patients that have more complicated infections. Because we know if you do have a positive follow-up blood culture, you're much more likely to die. And this is that study. It was published in JAMA Internal Medicine in 2022, and they identified 5 studies, all large studies, kind of every gram-negative bacteremia at a large community or university hospital. They had variable rates of positive follow-up blood culture positivity. That is concerning to me. Like at least 2 of these, at least GNL and muscarinic, those are much higher than has previously been reported. But nonetheless, every single one of them had a trend towards or evidence of benefit with getting a follow-up blood culture. And importantly, all of them controlled for survival bias. So, you hear this, you might immediately think, well, of course the people who lived long enough to get a follow-up blood culture were then more likely to continue living because they didn't die in the first 48 hours. And they actually controlled for this, and they still found there was this association. And so I think it made sense to have interest in this. However, multiple groups have independently investigated these findings, and then we now have another 4 studies that show absolutely no difference in receipt versus non-receipt of a follow-up blood culture. And every single one of these studies, in addition to the original 5 studies, find that if you get a follow-up blood culture, we're more likely to continue antibiotics longer, and we're more likely to keep you in the hospital longer. So we're exposing patients to more risk of harm without reduction of mortality. And I also want to point out that of all of the studies on these 2 tables, the one that's by far the highest quality was just published last year, the study by Ong, which reviewed 34,000 patients, essentially everyone with gram-negative bacteremia in the Ontario health system. And so much larger sample size than these others, did a very nice multivariable analysis and accounted for immortal time, and found essentially the same clinical outcome with and without follow-up blood cultures. Now, as a caveat, there may be a subpopulation of folks who might benefit from receiving follow-up blood cultures for gram-negative bacteremia. One of the original set of those studies, the one done at Duke by Muscarinic, actually they looked at their data and they came up with this little risk scoring system, which they call AIMS, which includes, not being immediately on effective therapy, having an endovascular source of infection, a cardiac device, having infection with serratia, which there are actually a couple different studies of prosthetic valve endocarditis and cardiac device infection suggesting that serratia might be more prone to relapse. It seems like it may be a little bit more sticky, may produce a little bit more biofilm, those sort of things that we often say about Pseudomonas. And so maybe folks who have multiple of these risk factors might benefit from having a routine follow-up blood culture, but it certainly doesn't need to be done in everybody. So again, my 3 practice changes that I hope you will incorporate for your own practice and advocate for others. Let's treat most patients with gram-negative bacteremia for 7 days. We can consider longer courses in folks who don't respond appropriately to early therapy, who have uncontrolled sources of infection, and who have other conditions like endocarditis or endovascular infection that requires further therapy. Switch to PO in most patients. I think this is the thing we should be reserving our fluoroquinolones for, and or Bactrim. If you can't use either of those, oral beta-lactams are an option, but I'd encourage you to use the maximum tolerated dose and consider going longer than those 7 days because we know that the data has a trend towards worse failure. And then last but not least, please, there's no need to obtain routine blood cultures for gram-negative bacteremia in all patients. Save that for folks who aren't clinically responding to therapy or who have other of these risk factors for recurrence. And that's my talk. Thank you very much. Happy to take your questions.